Section 6. I hope this wrap up video finds everyone doing well. Block 3 wrap up, man. I thought it was a really interesting block. I really liked hearing what everybody had to say. I think a lot of people were changed or at least thought differently after this week's or this block's articles. And it was great to kind of meet you guys where you're at and yet hopefully push some of you to think differently. We're going to go through that, but I enjoyed the conversations. I enjoyed the dialogue. I appreciate everybody chiming in. I appreciate people finding extra literature. I thought it was really great. Thank you for giving it a really good effort, this block. I really appreciated that. It was because it makes it more enjoyable for me to read because I really like digging into your thoughts and I enjoy challenging you where you're at. So, again, appreciate the effort. So, highlights from the week, or from the block, I guess. Treatment of ACL tears. So, this Froebel article really it rocked some people, it sounded like, and it made people think. And this article was written in 2010, right? So that was 9 years ago. And some of you, to your credit, went out and found other articles that have been written since that time to find out that there's a systematic review on this information that was done in 2016, and that there is a growing body of evidence that while surgery is certainly applicable to some people, and sometimes you may have, when I pushed, I may have made it sound like, well, surgery, everybody should just do conservative care. And that's not the case, right? Certainly, surgery is appropriate for some people, although why surgery is appropriate, I would disagree with some. A lot of people usually attributed high level athletes to needing surgery, and I don't think that's the case. I gave some examples of some high level athletes who do not have ACLs, who both in soccer and basketball, and I think there's a couple in football too, that have done well. Now, is that the exception to the rule? Perhaps. But do we really know? Because most people would have said we didn't know if people could even play sports without surgery at all, let alone there being anyone who could possibly do this, let alone there being anyone who could possibly continue on with hiking or biking or, who knows what. And I'm telling you right now that most surgeons don't make their money cutting on people who are returning to high level athletics like Division 1. Even we'll even go all the way down to Division 3. Oh, and then pro, right? Like they're cutting. That's a smaller percentage, and the majority of the people they're cutting on are the recreational weekend warrior who's like 24, 25, 26. Um, and I think we have to question that. And some people, they were like, well, that's just not politically feasible in the climate that we're in based on our revenue streams. And I would challenge you to think differently about that. And I would challenge you to be open to conversations, right? Where do we start? Are we blinded to the idea that this research exists, or do we enter into dialogue with respect for professions of all kinds? Saying, this is a possibility. When do we look at this? And what kind of dialogues are we having? Are we simply, at this point, kowtowing to people who are our referral bases, or are we asking harder questions? And I know I work with in the same system that Trent does, although Trent is a little bit more siloed. And if any of you got a chance to read some of his stuff, he works for a large boutique hospital essentially called TRIA, and all they do it's just an orthopedic boutique hospital, and they have a lot of fancy stuff. But we've entered into some conversations. My health system owns or is in partnership with this hospital, this orthopedic center, if you will. And we've entered into conversations and we've changed things just because we've been willing to ask the tough questions. Like, is this really what we want to do? We've worked on protocols that are not driven by physicians. We've worked on protocols that are driven by physical therapists. Which is how it should be. Why are they dictating what we do? They certainly understand what they did, but why are they not staying in their lane? I'm going to challenge you all to think differently. And I by no means want you to be disrespectful, or am I saying that we need to be disrespectful? But I think we need, as professions, to be respectful of not only what we do, but of what they do. And I would hope that they would return the favor and not view this as a threat. So I challenge all of you to think professionally about representing what you do and what the literature does, and ultimately what's best for the patient. Now, copers versus non-copers, that's what it all boils down to, right? Who are these people that are appropriate for this kind of care? and who isn't. And we still are searching for the best answer, right? One of the people that I like to follow a lot is Lynn Snyder Mackler, who is out of Delaware, who I just think is phenomenal. Crazy. She's just a great talker. If you're on Twitter, follow her because she champions her research on Twitter. She's married to an orthopedic surgeon, and she has some very interesting. I'm sure they have some great conversations because she is not. I mean, she basically says that this is a flip of a coin when you have this surgery, whether it's going to tear or re-tear or not, and her data backs it up. And she also says that you shouldn't be going out back onto the field until at 9 months. And I've always wondered, like, and she will say, I don't even know why 9 months. What happens magically at 9 months? I have no idea. So if you can pass those performance-based tests like the triple hop, single leg hop, alternating triple hop, right? Like it really doesn't matter if you can do it at 6 months. And as I mentioned to, gosh, who was it? Was it Alyssa? Where we were talking about the Adrian? No, it was Trisha about the Adrian Peterson effect. Like I lived that here in Minnesota. I mean, that guy was able to do some amazing things and return to football, and everybody else thinks that they can do that. And what they don't understand is what they need to put into this. So I have I could go on and on. I'm going to stop there, but there's lots around this. There's a lot of topics, a lot of opportunities to deep dive, and we are nowhere near figuring out best care right now. Best care right now is way too dominated by physician. So, NEOA, the use of manual techniques and exercise, the combination of the two. You know, there's some conflicting research on this. I think, in my mind, manual therapy is something that can be used in acute situations, and for those people, as Chad Cook so aptly put it, who have the ability to self-modulate. And chronic knee pain patients may not have self-modulating skills, and so therefore they're not going to be great for manual therapy. And we don't know who those people are. We know that they respond really well, but to keep doing manual therapy over and over again and expecting some kind of significant change probably isn't your best interest. If you see change with manual therapy in the first visit with someone with NEOA, keep doing it, right? But if you don't see change, it becomes an exercise-driven program, and there's nothing wrong with that. I think booster sessions in the future have legs. I think they got to figure out the best approach, but I definitely think that there is, especially those who are not in chronic pain, there's that kind of chunk in the right. There's the chunk in the middle of who have kind of who've had a kind of waxing and waning NEOA, which is pretty common. That's pretty much the pattern of NEOA. It waxes and wanes. You go through bad periods. It gets better, right? And the booster sessions are certainly something to think about. There's even a recovery article that I forgot to post that, with some really good information where you can continue to strengthen in maybe a less loaded knee joint while it calms down, and then roll back into more weight bearing. So I think booster sessions has their place, and I think that's where telemed is going to be big. And we didn't talk about that much at all either. Obviously, we have our limitations in what we can cover, but this is where telemedicine I think probably is going to have a future for us as we check in with patients periodically to make sure things are going okay. They can ask questions. They have a lifeline where they're going to come back to us and say, hey, what about this? Or do you have ideas about that? PFPS, think regionally, right? Whether it's manipulative techniques to the lumbar spine, mobilizations, manipulations to the knee or to the hip, right? What are we doing? We're not altering positions of anything. We're not realigning anything. We are simply providing an analgesic, a neurophysiologic input into the system to dampen down the nociceptive response to afford mobility, right? If I manipulate lumbar spine or lumbopelvic region and I get a reduction in patellofemoral pain, I've done nothing to the patellofemoral joint per se, but I've reduced that nociceptive signal, which may create this opportunity for us to strengthen. Some people I talked about with taping, right? And the value of taping has certainly been questioned. Maybe it works well, but maybe it's not really about a malalignment, and maybe it's a proprioceptive issue. I have a research article that I posted to a couple of people that looked at medial glides, taping immediately, taping laterally, and then taping just directly down in neutral. And believe it or not, everybody got better. Why? Not because it was repositioning anything, but simply because it was providing a proprioceptive input that was reducing that nociceptive signal, or perhaps providing a mechanical sensation, like how the gate theory works, and reducing the nociception, or providing a focused mechanical sensation that overwhelmed the nociceptive signal. So many things to talk about. But such good stuff. Okay, so Next block. Well, before I go to the next block, I would just say on the case study that I think everybody got to it. I would argue that well, one of the things that I challenge some people on is, do we really need treadmill assessment? Is there value in gait assessment? Where does the research point us on gait assessment? Do we need to be doing slow mo running analysis? Is there value in that? I would argue that the research is pretty mixed, if not even contrary to that, saying that if you can see it across the room, that's probably should be maybe that's something they could work on. But oftentimes, these like nuanced, increased calcaneal valgus or varus, these quick steps, the cadence changes in running has been shown to be somewhat effective. So maybe there's value there, but that's really just about education. So we're talking about gait analysis and those kinds of things. Anyways, bottom line is, I would have argued that the biggest for me, the biggest indicator is she gets pain with a heel rise, resisted dorsiflexion. So that's always going to be my go-to. If I get rid of that, then I know I'm in, right? And how am I going to get rid of that? Well, you're gonna see her do a treatment, and I would argue that I probably wouldn't have spent nearly as much time mobilizing this ankle. Uh, but I shouldn't. I'm leading into what's going to happen, so I'm going to stop now. I'll give more information in block 4. Okay, so evidence-based management of the foot and ankle disorders and return to sport considerations, patient case, treatment focus. That's where we're going to lie. Go back to, if there are questions, obviously give me a shout out. I was a little bit more. I didn't send any emails out this week because I felt like everybody was just kind of rolling, and we're now into the third block, and you guys should know. And I won't be sending out any comments. Right, only comments will come in block 4 as we wrap up the course. Otherwise, enjoy your weekend. It's beautiful here in Minneapolis. What a beautiful fall day. The colors in the trees are absolutely spectacular. Just a great fall day. Hopefully it's great where you're at as well. And I look forward to wrapping up this block 4, or engaging into block 4 as we start to look toward the end of the course. I'll take good care. Bye-bye.